Thank you. Thank you, Sachin, for the kind introduction. And thank you to the panel, the invitation to present. It's my pleasure. I do have a cold, so excuse my voice or if I'm coughing, but I'd like to start with that this is, I have no financial disclosures. I'm unable to advance first. Okay, here. I have no financial disclosures, and this is adapted. This presentation is adapted from a course we did at the American Academy of Ophthalmology, and these are my co-course instructors at that time, and Asim Sharma, who is my husband and a professor of neuroradiology at University of Michigan, and the neuro-ophthalmology team at University of Michigan is listed here, and definitely a big contribution for all of them to this presentation. So what I want to emphasize that though neuroimaging, getting proper neuroimaging is very important, as Dr. Golnick's talk just emphasized. And some of the errors are interpretive errors, where the neuroradiologist or the general radiologist who read it made the error. But some of them are prescriptive, which is how you ordered it. And we are responsible for the care of the patient and the final outcomes. So it's important for us to know both errors. So let's look at the prescriptive errors, the errors that you make in ordering. So one of them is if you don't obtain the correct study, you are responsible for localizing where the lesion could be and target your study to that. And then if you order without contrast, when it should be with contrast, that's a problem. Or we may not know of every specialized sequence that exists, but some general ones, and taking the help of a neuroradiologist is important here. And the interpretive errors, if you give misleading clinical information, they are looking at 200 plus images for every patient, and the actual problem might be seen in 2 or 3 out of those. So it's like looking for a needle in a haystack. So you need to give them what are you exactly looking for. Imaging may not be sensitive enough for the disease, so remember that. There might be something reported that is actually not explaining. So be aware of not every positive report is the answer to your question. So in this next few minutes, I'm going to talk about a few scenarios that you'd all deal with, and talk about when is imaging needed, what kind of imaging should be ordered, and what will the imaging show so that you are prepared to interpret that result. And if it's not showing what you wanted, going back and discussing with the radiologist. And also we'll talk about when will imaging let you down, where are those errors that were made. So let's start with a clinical scenario similar to Dr. Golnick's case. So a 76-year-old woman noticed binocular double vision and drooping of her eyelid 2 weeks ago, and headache for 1 week. She has a past medical history of diabetes and hypertension. And you examine her, the vision is 6/6 OU. The pupil is on the right, the eye with the droopy eyelid is a little dilated compared to the other, but less reactive. The rest of the anterior segment exam is normal, and this is how she looks. So here you have complete doses, and the eyes out, maybe a little bit down. So you're all thinking, okay, down and out, complete doses, it's a third nerve palsy. And you can see the pupil is affected here. The rest of the cranial nerves look normal. And we have a complete, almost complete third nerve palsy, pupil involving. So what is our concern? As you've seen, our urgent concern is an aneurysm because of the way the third nerve and the the arteries run closer, especially the posterior communicating artery. So what kind of imaging is best in this scenario? There are certain nuances which vary from place to place, but what we all agree is it's going to be an arterial imaging, and we want, what is the region of interest? Of course, it's the course of the third nerve. So we want to emphasize that. When should we get it? This is super urgent. So it's emergent because of morbidity and mortality, as you just heard, from a ruptured posterior communicating artery aneurysm. So what you tell the radiologist on your requisition, or if you pick up the phone and call, you need to say it's a third nerve palsy, rule out the posterior communicating artery aneurysm, and specify which side. So what kind of, now we know it's an arterial imaging we want, so we could do CTA or MRA. The advantage of CTA head is that it's more available at most centers, and there's a speed in acquisition, and there's less chance for motion artifact. CTA with contrast is what is the preferred at University of Michigan. We want a neuroradiologist to read it and confirm to us that there is definitely no aneurysm. And if we also want to look for another cause, which is followed up by an MRI with and without contrast. And in that case, we want a cranial nerve protocol imaging, but that can be done in the next few days. The aneurysm is the urgent concern. So what's the pitfall here? The radiologist must have expertise. You know, it's a general radiologist saying, oh, I don't see an aneurysm, may not be enough. If there's a pupil involving third nerve palsy, you want a neuroradiologist with expertise, and they also have to make sure that the study was adequate, have the posterior communicating arteries been entirely visualized in that study. So let's look at this. How would they see it? This is a CTA showing, this is showing a right PCOM aneurysm, and you can see it as an outpouching. And here is a reconstruction where, again, very clearly, you can see the outpouching. So this is what happens if it goes, this was a patient who ruptured within less than 12 hours of diagnosis. You can see all the blood filling these in the CSF from the ruptured aneurysm. And so you may get a report, oh, there's an aneurysm. This patient actually had a left third nerve palsy, and they said, oh, there's an aneurysm, but the aneurysm was a tiny aneurysm in the wrong spot. This was a small left ICA intracavernous aneurysm. This would not explain third nerve palsy, which is in the wall of the cavernous sinus. So this patient actually had, this was her scans, which actually had a left third nerve schwannoma. Remember that when you do the MRI, you want special cuts. A routine scan may not show the details of the third nerve. On the right here, you can see the cranial nerve protocol, which is very thin cuts. Also that will allow you to visualize. And contrast enhancement is important because, as you see, sometimes the nerve can enhance, as in this case of sarcoidosis as a cause of third nerve palsy. Going to our clinical scenario 2, which is actually similar to the patient that Dr. Golnick again had, a ptosis with a car accident and pain, unequal pupils. I won't go over this again, but what kind of imaging is urgent for you? You know that dissection is urgent, so we want the arterial imaging, and it's a carotid artery in the neck to the skull base is what you want to image. You also need the entire sympathetic chain. For the isolated corners, we tend to just go from the T2 to the base of skull because in the brain, they would have other features. So acute corners is urgent, as you've heard, because of the risk of stroke from carotid dissection, and that's greatest within the first week. And so we do send the patient to the ER for imaging. And what we tell them is we want to rule out a carotid artery dissection. So let's look at Our protocol is to do a CTA neck, again, because of the accessibility, less motion artifact. And that CTA is sometimes enough to give them soft tissue for any tumors in that area as well. So let's go to the, in the interest of time, I'm just going to show you what you would expect to see. So this is showing it on a CTA, you'll not see that nice sign that Dr. Golnick showed you, but a narrowed artery and will be the sign of dissection. This compares the CTA to the MRI. The MRI will show you the hematoma in the vessel wall, whereas CTA would just show you the narrowing. So, of course, you can have tumors. So let's go to the third scenario here. Is a patient that Dr. Kathleen Digray presented. When you have patients with papilledema, with what kind of imaging and how urgent. You of course want to look at the brain, but you also want to image the cerebral venous sinuses. So don't forget those. And when do you need them? If it's usually urgent, you may not send to the emergency room unless they're having vision loss. And if they suddenly developed nausea, vomiting, then of course, if it's an incidental detection, you might want to wait 1 or 5 days. And again, in this case, you want MRI brain, but you also want an MR venogram. And with contrast, it gives you better visualization of the venous sinuses. You can get a CT brain and CT venogram instead of the MR if MR is not accessible. And if you order without contrast, you may not see as well the details, but be aware that these are female patients who may have they may be pregnant, and in contrast is contraindicated if they're pregnant. So what to expect, the usual signs, and I just want to, I'll just, in the interest of time, just go to these in the venous sinuses. You may see a venous sinus stenosis on the venograph, but there might be a hypoplastic, which is a normal variant, so that you need to be aware of. That is not a sign of raised inguinal pressure. And then you may find other things. So I'll just jump to my a few slides showing the without contrast, non-contrast here will show you, sometimes show you a false positive. So you need to be aware that you want with contrast, which will show you less false positive venous sinus thrombosis concerns. So I'm going to jump to my summary in interest of time. So let's go there. The summary is that I had more cases than maybe we can discuss later, but the summary being communication with radiologists is key. You have to specify the region and lesion of interest and know what to expect. Read the report, discuss with the radiologist if something doesn't match. So that is all that I have. Thank you so much.